We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date, in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. Thank you, ma'am. So we'll start off with the case of precocious puberty. And this is a scenario which is very, very commonly encountered in pediatric endocrine practice and also in gynecology practice, but there are a lot of confusions which are there. So we'll try to use basic case-based approach to highlight the importance. So we had this 7-year-old girl with thelarchy who had a stage 2 breast development. She had no periods and had a pubic hair stage 1. She was a normal height individual and the bone age was normal. So this girl was referred to me for evaluation and management of precocious puberty. The key point here is that she is not tall. Now, we normally expect every girl who is coming to us with precocious puberty to be tall. She is not tall, which is a bit of a concern. Bone age is also normal, which is unlikely. Now, she was recommended GnRH analog by other clinicians. And when we did further evaluation, we found that the vaginal mucosa was red. So as I said that this child did not look like precocious puberty. So the best thing is to look at the vaginal mucosa, which will tell you if it's pale, it means that it is pubertal. If it is red, it means it's prepubertal. So what actually was happening here that she did not have a true breast development. It was only a lipomastia, which was misdiagnosed. So we have cases which are misdiagnosed and we have cases which are missed. So this is something which we want to really highlight. So precocious puberty is reasonably common. Approximately 0.2 to 2.5% of all girls will have precocious puberty. 90% of this will be physiological and 10% will be pathological. But it does not mean that the physiological will not have an impact on their height. The major concern is their final height. Our aim is to identify these disorders and to identify the girls who will need treatment to achieve a good height, while not unnecessarily giving treatment in other scenarios. So just a brief overview, you know there are three major organs and three major hormones which are regulating the pubertal development. So the GnRH coming from the hypothalamus is continuously being suppressed before puberty using the negative signals which are GABA and MKRN3. And in appropriate situation and age, and if the body has enough nutrition, the GnRH will then go and act on the pituitary to produce LH, which predominantly acts on the theca cell to produce androstenedione, which is aromatized via the FSH-dependent aromatase into estrogen. So in a girl, you need both LH and FSH to produce estrogen, while in boys, only LH alone may be good enough. This is something which is very, very important to understand. Now, estrogen acts on the estrogen receptor to cause effect on the breast, on the growth plate, as well as the uterus. So a major effect of estrogen is to cause growth acceleration and bone age acceleration. So if you have a high estrogen, you will have a rapid bone age progression. Child will look tall, but she will land up short if you do not do intervention. That's the key message that I'd like to give, especially for the gynecologist colleague out here. Now, adrenal is another organ which is producing DHEAS. This is a source of androgens. So gonadarchy and adrenarchy are two different terms altogether. So breast development and pubic hair development are two different facets of physiology. If we should not always think that they will go side and side, and there can be different issues in that regards. Very importantly, TSH has got structural homology with FSH. And if your TSH levels are extremely high, it will act on the FSH receptor to produce ovarian cyst. That will result in peripheral precocious puberty in a short girl. Every girl with precocious puberty is tall. If you have a girl with precocious puberty who is short and has large ovarian cyst, this means this could be hypothyroidism, which I'll highlight subsequently in that regards. So problems can happen in the central scenario, and this is regulated via the adipocyte. And adipocyte, if you have got enough leptin, it will then say body, okay, this is the time to go into puberty. There is also a peripheral production of estrogen via the adipocyte. So in obese girls, you may have an earlier onset of puberty. But very importantly, in many of these obese girls, thelarchy will happen, but they will be a very slow progression. They will not progress very rapidly. So you have to decide whether you want to treat them or not. On the other hand, if you have a small for gestational age, lean individual with precocious puberty, this is a rapidly progressive puberty. Because you expect puberty to be delayed in somebody who is undernourished. If they are already undernourished and having early puberty, it means it's something wrong out there. So BMI becomes an important criteria. Just a few words about pubertal assessment, and the most important parameters to look at are breast stage 2 and breast stage 4. So breast stage 2 is just any papilla elevation, but always differentiate it from lipomastia. Approximate your thumb and finger. If you find a resistance in the areolar area, that's true breast development. Otherwise, it's a lipomastia. From here, the girl will start growing, and she will have around 2.3 years mean from B2 to B4. And then from there, she will have vaginal discharge and menarche. The average growth from stage 2 breast is around 20 centimeters. Average growth from stage 4 breast is around 10 centimeters. And average growth from menarche is around 5 to 7 centimeters. So always put height and add that and see what is happening. So if you have a 130 centimeter girl at B2, she will be around 150. If she is at B4, she will be 140. But if she is having menarche, she will be 135. So you need to just look at the actual pubertal status and then decide whether intervention is required or not. Vaginal discharge means in the next 6 months, you will most likely have periods in that regard. Now, pubic hair progression is independent of gonadorrhea. What I'm more concerned is about P3, stage 3 development. Stage 2 development may be physiological. So if you have long, pigmented, curly hairs, that's a sign of progressive puberty. P2, wait and watch, don't do unnecessary workup. And of course, stage 4 and 5 becomes important from that perspective. Now, very importantly, we need to understand the hormonal course of progression. And we know very well that the FSH levels remain high in the prepubertal stage. And they increase by 2 to 3 times during puberty, while the LH level increased by around 20 times during puberty. So which is the best marker for pubertal status in a girl? It's LH and not FSH. So if you want to do one thing, look at LH. If your LH level is more than 0.2, newer assays, 0.2 is very good. That is pubertal. Less than 0.1 is prepubertal. What about reproductive organs? Now, we need to understand that there is a growth of ovaries and uterus. And the first change in the uterus which happens during puberty is the change in shape of uterus from a tubular structure to a globular structure. Then your length will increase above 3.4 centimeters, and then endometrial thickness will start to appear. So looking at ultrasound is a very, very important tool in this perspective to identify in that regards. If your length is above 32 millimeter and not centimeters, 3.2 centimeters, I would say, volume is more than 2 ml, this is puberty. Precocious puberty in girls can be either incomplete, only breast, only pubic hair, only bleeding, or it could be complete. Now, if you have isolated menarche, this is not really a precocious puberty. This is a local cause. No breast, no pubic hair, only vaginal bleeding. This is trauma, tumor, abuse, infection, all other things, not endocrine. If it's complete, it could be central in most cases where it is idiopathic. But if the onset is before 6 years, you need to think of a CNS lesion in which there could be a pathological cause, rarely genetic disorders. Peripheral precocious puberty, because of an ovarian cause, is rare. It usually is associated with ovarian cyst, and you can very rarely have adrenal tumor. So most of your cases will be isolated thelarche or pubarche or a idiopathic central precocious puberty. You do not need extensive evaluation in that regards. The question is it precocious puberty? If it's precocious puberty, is it complete or incomplete, central versus peripheral, and what's the cause? So precocious puberty in girls is defined as pubarche and thelarche happening before 8 years of age, or menarche happening before 9.5 years of age. This is what you need to really understand. Now, you can assess pubertal status using estrogen, but estrogen at low levels is not reliable. So you may have normal levels also. What I will more rely is vaginal mucosa. If the vaginal mucosa is pale, it suggests that you have a estrogen exposure. If it's a red mucosa, it means it's a non-estrogenized vaginal mucosa. Endometrial thickness above 2 mm, growth acceleration, and bone age acceleration. And this is very important. You have a tall girl, but her bones are much, much more advanced than that. So this will result in a final height which is compromised. And of course, discharge and abdominal pain will give you a clue. Now, whether it's complete or incomplete, if you have only breast development, this could be an isolated thelarche, but this could also be a progressive puberty. So you have to really look at here what might happen subsequently. If you have only pubarche, this could be idiopathic, it could be CAH, or rarely adrenal tumor. So how much is the adrenarche? How much is the DHEAS level? That will give you the clue. And finally, if you have isolated bleeding, this is trauma, tumor, and abuse in that regards. So if you compare central versus peripheral, you have to look at a LH level. If LH is above 0.2, this is suggestive of a central precocious puberty. We don't usually now do a GnRH test in that regards, but you can do it in certain scenarios. Very important clinical clue, look at breast, look at pubic hair, and you will get a diagnosis. You have only pubic hair, no breast development. This is adrenal problem. It's not an ovarian problem. No breast, no pubic hair, bleeding. This is a gynecological problem. If you have breast development, but you have got no pubic hair development. This is hypothyroidism. You have normal breast, normal pubic hair development. This is a central cause. This is a central precocious puberty. So a combination of this will give you a clue clearly in that regards. Now, workup includes gonadotropins, and if you need GnRH analogs, if the LH is pubertal and a girl is below 6 years, get an MRI done. If it's a prepubertal LH, do an ovarian and adrenal imaging in that perspective. Bone age is essential to see the height compromise, and thyroid also becomes important in scenarios along with an ultrasound from that regards. So the approach, if you have only pubarchy, get a DHEAS done. If DHEAS is normal, this is nothing to worry. It's an idiopathic phenomena. If it's in the adrenarchy range, wait and watch. But if it's very, very high, then you should think of CAH. So DHEAS, very, very important in a girl with precocious pubarchy, because this could be an adrenal tumor or CAH. If vaginal bleeding, local cause. If it's a complete or thylarchy, get a bone age. Bone age is retarded. Most commonly, this is hypothyroidism. Bone age is normal. This is slowly progressive. Bone age is advanced, then this could be central versus peripheral. So I would say look at clinical clues. You will get the diagnosis in most cases. Club with bone age, you will get the diagnosis again in that regards. So this is the case I already discussed. 7-year-old girl falsely labeled as precocious puberty when she only had a lipomastia. So just by doing clinical examination, you would not have done any test in this girl. 2-year-old girl with thylarchy, clear-cut breast development, which is happening. Onset 6 months ago, this is slowly progressive. Stage 3 development, which is there. Now, this could be isolated thylarchy. So what we recommend is that get a LH-FSH. If LH is normal and ultrasound is normal, don't worry. Most girls presenting between 1 to 3 years with just breast development do not need extensive management. But do document their LH. Do get an ultrasound to be sure, because this could be a hypothalamic hematoma also, which is causing the same thing. But this is a simple isolated thylarchy. Now, other case, 2-year-old girl with vaginal bleeding, thylarchy 3 months ago. So a recent onset breast development, and then you had a bleeding. She is having no pubic hair development. So this is a strange scenario, and bone age is advanced. So in this case, I will be worried. If you have very rapid onset menarche within 1 year of thylarchy, this means it's a hyperestrogenic state. Estrogen is hugely high. You can see LH-FSH is low. So this is coming from the ovaries. So this case, clearly you have an ovarian cyst, and then you think of macunal bed. Then the other workup will be done by the endocrinology colleagues. 1.5-year-old girl with menarche, breast stage 2, no pubic hair development. She's tall. And what you are seeing, again, the LH is very, very high. So I have already said that most girls with early puberty at 1 to 3 years may be normal. But menarche is not normal at 1 to 3 years. And you are seeing very high LH and FSH. This is something pathological. And MRI showed a lesion, which is known as hypothalamic hematoma. Now, hypothalamic hematoma is a normal tissue in an abnormal area. It does not require surgery. Do not refer them to a neurosurgeon, because they will ultimately go for surgery, and this can cause a lot of confusion. So again, diagnosis of hypothalamic hematoma is important. 7.5-year-old girl with pubarchy, birth weight 2,200 grams. So she is a SGA, small for gestational girl, who now is gaining weight, has breast development not there, but pubic hair development, and DHEAS is marginal. Very common presentation, SGA girls have insulin resistance, and this leads to the development of precocious pubarchy. They may develop PCOS and other things later. At the moment, however, DHEAS is not very high. I will follow up, advise weight loss in that regards. On the contrary, 6-year-old girl with pubarchy who was non-SGA. This is important, non-SGA. She is much more taller than the previous girl, has got a very high level of DHEA. So this girl requires evaluation. This could be an adrenal pathology, and this turned out to be CAH. So you need to understand what is physiology and what is pathology. That becomes very, very important in that regards. 7-year-old girl with vaginal bleeding, 1 episode, no breast, no pubic hair. Vaginal mucosa red, diagnosis. So it's a local cause. We are not talking about an endocrine cause. And this happened to be a foreign body. So all those things have to be considered. So a gynecology referral is important. 6.5-year-old girl with menarche, last 1 week she had thilarchy. So very recent thilarchy and menarche. She is okay, not very short, not very tall. She has got no pubic hair development, no cafe au lait spots, zero LH, zero FSH, high estradiol. So what does it mean? There was a source of estrogen recently, which produced a lot of estrogen, and then it went off, and that's why you had a withdrawal bleeding. So this is a classical presentation of a functional ovarian cyst. So always look at breast and menarche, you will get the diagnosis there in that regards. 7-year-old girl with thilarchy, 3 months of age, she is extremely short. First sign, short girl with precocious puberty raises an alarm. She has a large ovarian cyst. And in fact, she was being referred for surgery. And when we saw the child, she had all the features of hypothyroidism. So this is a child who is short, delayed bone age, large ovarian cyst. Think of hypothyroidism as a possibility. TSH is more than 100. Now, I'll just summarize here and probably stop in a couple of slides about management. Now, management is very good with GnRH analog treatment, which is there for girls. But what you need to remember is that you should not give it to everybody. If somebody is below 6 years of onset, 100% treatment is required. Between 6 to 8 years, if the bone age is very advanced, then only treatment is required. Otherwise, you don't need to treat. GnRH analog will basically desensitize the pituitary. You will have initial flare and then the levels will go down. And what you are expected is that you need to give at the accurate timing, very importantly, because if you delay, they will have flare every time. So when we say 12 weeks, it is 12 weeks. Don't give it at 14 weeks because then your whole treatment will fail in that perspective, and that becomes important. It has no effect on pubarchy because that is coming from the adrenals. And in somebody who is intellectually having a problem like cerebral palsy, you just want to control periods, we give medroxyprogesterone acetate, but it is not going to benefit in terms of height. It is bad for bones. So it's not a good drug overall. So just to summarize, for treatment of precocious puberty, if the age of onset is 6 years, don't worry. You need to treat. If the age of onset is about 8 years, no treatment is required. 6 to 8 years, and if you have progressive puberty, that means you're tall, your bone age is too advanced, or you have a uterine features of a size about 34 mm or an ET of 5 mm, this is clearly treatment is required. Otherwise, you follow up for 6 months to really make a diagnosis and they're progressing to treat. Otherwise, treatment is not required. So age, uterus, bone age, only 3 things you will need to do in terms of achieving the treatment. This is very, very important. Most of your girls will actually come somewhere around here. So follow up. But yes, 20-30% will come at the wrong time. And if we don't treat them, they will have short height. And when they come to us, it is too late for us to do anything. So don't treat unnecessarily. But when it is required, we should have an immediate referral also in that perspective. And the preparation that we normally use in this setting are essentially the leuprolide is the most common preparation which is used. And the usual dose is approximately 11.25 milligram, which we give around 12 weekly. If a girl is presenting very late with menarche, do not start on a 3-monthly preparation. Start on a 4-weekly preparation to allow less flare. Otherwise, the bleeding will be too much. The other options were triptorelin, goserelin, and hystrelin, but now leuprolide is the one which is very easily available with reasonable cost efficacy. And you expect breast to go down, growth to become normal with no effect on pubarchy. We expect a height gain of around 10 centimeters if it's below 6 years and around 6 centimeters if they have onset between 6 to 8 years. So you need to be thinking of it. But every time you give GnRH, you will have a flare.